the metacarpophalangeal joint is subluxated. This is the earliest and the treatable pseudodeformity. The piano key deformity is the deformity where there is the rupture of the ulnar collateral ligament. The ulnar collateral ligament of the wrist joint causes the elevation of the ulnar styloid process. That is why it is known as the piano key deformity, and this is also treatable. And the hitchhiker sign is because of the abduction and extension of the thumb. Abduction and extension of the thumb. This is the hitchhiker's thumb. Abduction and extension of the thumb. This is also treatable. So the three pseudo deformities are zigzag deformity, piano key deformity, and hitchhiker's thumb. True deformities are the Boutonniere's deformity, swan neck deformity, Vaughan-Jackson deformity, intrinsic plus deformity, opera glass hand deformity, hammer toe, and hallux valgus deformity. True deformities is the Boutonniere's deformity, subluxation of lateral band of extensor tendon at PIP. The lateral band. This is the lateral band. PIP joint lateral band of the extensor tendon is subluxated. That is why this happens. This is the Boutonniere's deformity at the PIP joint. So this is the Boutonniere's deformity. This is the Boutonniere's deformity. Extension is not happening here and extension is happening here. So this is the Boutonniere's deformity. And swan neck deformity is of the PIP joint. Rupture of the FDS of the PIP joint and extensor tendon of the DIP joint. FDS tendon of the PIP joint and extensor tendon of the DIP joint. Whichever is flexing, extended tendon is ruptured, and whichever is extending, flexor tendon is ruptured. Here the extensor tendon, ulnar collateral tendon of the PIP is not ulnar collateral, lateral band of the extensor tendon at the PIP is subluxated, causing Boutonniere's deformity. Swan neck deformity is formed by the rupture of the FDS at the PIP joint and extensor tendon in the DIP joint. Vaughan-Jackson deformity is the sparing of the index finger, rupture of the external carpi ulnaris tendon, extensor carpi ulnaris tendon due to the attrition over the distal ulnar head, followed by medial to lateral extensor tendon rupture. Only the index finger is spared. The flexor carpi ulnaris tendon, medial to lateral extensor tendons are ruptured. So this is the Vaughan-Jackson deformity. Index finger is spared. Intrinsic plus deformity is due to the tightness of the intrinsic muscle resulting in flexed metacarpophalangeal joint and extended interphalangeal joints. Extended interphalangeal joint and flexed metacarpophalangeal joint. This is causing the intrinsic plus deformity. Opera hand is the arthritis mutilans. This due to the extensive destruction of phalanges. Hemato is due to the extensor tendon subluxation of PIP, a DIP, and hallux valgus is due to the medial collateral ligament. So, other forms of manifestation is elderly RA. Elderly RA is 15%. The 60% is this chronic inflammatory seropositive RA, and elderly RA is 15%. This is explosive small plus large joint polyarthritis. DD is giant cell arthritis, that is polymyalgia rheumatica, and arthritis robustus, which is elderly, erosive and painless, affects the elderly, and it is erosive and painless, arthritis robustus. And palindromic RA is anti-CAR peptide antibody positive and single variable joint normal between the flare. It behaves like gout. At 50% of them develop RA. It is anti-CAR positive antibody is present, and there is a single variable joint, and there is no symptoms between the flare mimicking gout, and 50% develop RA. What are the extra articular manifestations? Extra articular manifestations are these. CNS involvement is from the C1 C2 subluxation, causing the quadriparesis due to the compression of the spinal cord. X-ray CS lateral spine is done. So in the joint involved, we have seen cricoarytenoid, TMJ, C1 C2 atlantoaxial joint, and distal radioulnar joint, metacarpophalangeal joint, proximal interphalangeal joint. So C1 C2 atlantoaxial joint causes quadriparesis seen by cervical spine X-ray lateral view. In peripheral nervous system, small fiber neuropathy is seen. In CVS, vessel and heart vessel causes medium vessel vasculitis, small more than medium, and it is responsive on rituximab. On the vasculitis feature, there is ulcer, gangrene, mononeuropathy, intestinal infarct, and this mononeuropathy is actually the small fiber neuropathy. Heart pericarditis can occur, valve deformity, MR more than AR, and this is known as the MI equivalent because of the vessel affected. Kidney secondary amyloidosis resulting in membranous nephropathy. Ocular episcleritis, scleritis, and keratoconjunctivitis sicca occurs. Most commonly is the episcleritis is the most common ocular feature, and scleritis is also known as scleromalacia perforans, and the most common cause of dry eye is keratoconjunctivitis sicca. So episcleritis, scleritis, and keratoconjunctivitis sicca. Scleritis is known as scleromalacia perforans, and ocular episcleritis is the most common feature. Keratoconjunctivitis, Zika is the most common cause of dry eye. Hematological changes হচ্ছে warm antibody IgG, autoimmune hemolytic anemia can be caused, secondary ITP and DLBCL. So RBC তে autoimmune hemolytic anemia, warm antibody against IgG, secondary ITP and DLBCL. Large granular leukemia, Feltis syndrome. What is Feltis syndrome? Feltis syndrome is neutropenia, rheumatoid arthritis and splenomegaly. DRB104 is involved in Feltis syndrome. Antibody against citrullinated histones are present. RA nodule and deformity is to be present. Feltis syndrome is neutropenia, RA and splenomegaly. In RA nodule and deformity is to be present. HLA DR104 is responsible and antibody against citrullinated histones are present. This is hematological. Non-articular Baker cyst and auricularal bursitis can occur. In lung, pleuritis, unilateral lymphocytic exudative pleuritis which is occurring is unilateral lymphocytic and exudative. There will be increased LDH and decreased pH. The most important factor we need to remember that the sugar is decreasing in RA. Normally it decreases if there is any bacterial infection, but here LDH is increasing, pH is increasing. This is exudative in nature and sugar is increasing, but this is RA origin. Unilateral lymphocytic exudative, sugar less than 30, LDH increasing, pH decreasing. Kaplan syndrome is pneumoconiosis, unilateral upper lobe nodule, and ILD is UIP. All other connective tissue diseases have NSIP. Here it is in UIP. UIP features are honeycombing, cystic and traction bronchitis, and anti-PAD 1 to 4 antibody is to be present. The patient is male smoker and decreased DLCO. COPD can occur, obliterative bronchiolitis can occur. Now coming to the management of rheumatoid arthritis. This is the management is based on the theory of treat to target. What are the targets? Okay.